be continuing from where and now the aim of this talk is basically to introduce you to some of the other things which you need to consider when you are evaluating a test. So I will be predominantly speaking about what is sensitivity, specificity, what are predictive values, what is the use basically when you evaluate them as a statistician, and how you can go about understanding them and using them. Now basically Siddharth has already talked about normal and not paranormal but abnormal distributions. But as we all know, statistics can sometimes be a bit confusing, but the thing to keep in mind is that it's not as difficult as people believe it to be. And once you get into a regular practice of trying to apply it when you are reading any article, applying it towards any review of literature, you start getting a hang of it, you start realizing what it is, why you need to use it, and it does sometimes lead to some important information. So as I said, sensitivity, specificity and predictive values are something which we'll discuss. Now basically these are the things which you need to consider when you are evaluating any test. So what are the ideal parameters of a good screening test? Number 1, should be acceptable to people. Number 2, it should be repeatable. And number 3, there should be validity. And when we talk of validity, there comes these two entities, sensitivity and specificity. But first of all, what do we mean by repeatability or precision? Now if you look over here, now even this and this, both of them have got something in common, which is that they are both pretty repeatable. They are giving the same values again and again, both of these tests, if you look at these dartboards. But this one is not precise. So it's accurate or inaccurate, but then there is something called precision and an imprecise reproducible error. So both of these are precise, meaning thereby they are both repeatable. Whenever you do a test, they are giving the same values again and again. You test a machine, let's say you test a newer method of IOP measurement. So the machine is giving repeated same results, but then, so it's precise. That means that the measures are repeatable, but they might not be accurate. So before we go on to that, there are some things which we need to understand. What is a 2x2 table? What is sensitivity and specificity, and positive and negative predictable values? So now this basically, this table is the crux of all we'll be dealing with, and something which we had earlier read in our PSM classes and later on. So this is something. So when we talk about a test can be positive or a test can be negative. We are evaluating a disease over here. So now we have to remember two things. Is a disease present or is a disease absent? So if a disease is present and your test is coming to be positive, elementary, that means it's a true positive result. However, there might be a condition in which the disease might be present but your test will be giving a negative value. So that's a false negative result. Similarly, a disease might be absent and your test might make it or might give a result which is negative. So that is a true negative value. However, there is a chance of error, and so your test might come positive in spite of a disease not being there. And that is basically what we mean by something which is a false positive thing. So now we move on to sensitivity. So basically the ability of any test to identify correctly all of those people who have a disease. That is an inherent capability of any test to identify the true positives. That is the test sensitivity. Specificity is basically an ability of any test to identify correctly all those who do not have the disease, or what we mean by true negatives. Predictive values basically are, if a disease or a test is positive, how likely is it that the person in question has that disease? Now that depends upon the prevalence of a disease. How prevalent is that disease in a particular population? Similarly, if your test is given a negative value, how likely is it that the individual does not have that disease? Those are predictive values. Now basically what they depend upon are the thing, as in what I just said earlier, a positive test indicates the probability that a person with a positive test has in fact the disease in question. Similarly, a negative test indicates that the person who has a negative test does not have the disease in question. So let us basically go on to some examples and then see what we meant by this. Is something which I just discussed in the previous, the 2x2 table. Again the same again, we will be going through this table again and again, because this basically, once you get this clear, you get a hang of what we mean by sensitivities and specificities. So let's take a hypothetical example. There is a population of 100 where disease A is present in 10% of population. So now a new test has been devised to detect that disease. So the disease is present in 10 people. out of which your test has positively tested 8 people, or 8 people have come to be positive. However, 2 people who had that disease were not detected by it. So that's a false negative. Now disease is absent in 90% of 90 people, and your test has given 85 people who do not have the disease as having a true negative, or they do not have the disease. However, there are 5 people who have tested positive by your test. So that is a false positive. So when we say the sensitivity is basically a ratio of true positives to the total over here, the true positive plus false negative, which is something around 80%. Move on to specificity. Specificity is a ratio of your true negatives to the total over here, which is B upon B plus D, which comes to be 94%. So this test is 80% sensitive, and 94% specific. Now we move on to positive predictive value. So the positive predictive value is only 62% for this case, which is true positives upon those whom the disease is identified to be positive. So that means out of those people who have been identified, there's 62% probability that this person has the disease in question. And a negative predictive value will be 98%. So predictive values depend upon the sensitivity and specificity along with the prevalence of the disease in population. In fact, if you look over here, another example of the same condition, let us say that you have got a test which is giving a true positive value of 16 and a false positive of 5. So your positive predictive value is 76% over here, and a negative predictive value will be something around 95% over here. For a test with a sensitivity and specificity again of 80 and 94%. So if you look over here, the sensitivity and specificity are the same as what they were in the previous question or previous example. However, as the prevalence changes, the positive and negative predictive values also change. The same example, let us say that now the disease in question, the number of patients has increased to 40. So that means that there are 32 people who are positive, 8 who do not have it. Again, disease is absent in 60. That means the false positives are 4, but true negatives are 56. Again, the same sensitivities and specificities. But now look at it. The positive predictive value has improved to 89%, and negative has dropped down to 87%. As I said, look at this point. The sensitivity and specificity remain the same. So basically what I mean to say over here is that predictive values are directly associated and affected by a disease prevalence. So for a same test which has got a 80% sensitivity and 94% specificity, if the prevalence is 5%, positive predictive value is 40. But now keep on looking at it. As the prevalence increases, the positive predictive values also increase, whereas the negative predictive values decrease. So over here, look at it. The same disease, if it is prevalent in 60% of the population, then your positive predictive value with the same sensitivity and specificity improve to 96%. So a highly sensitive test is basically more helpful to a clinician when the test is negative. So remember this mnemonic, SNOUT, something which is very commonly mentioned a lot of times. SNOUT means high sensitivity and a negative test rules out a disease. Similarly, the other thing to be remembered is SPIN, or a high specificity and a positive test rules in a disease. So SNOUT and SPIN, remember them, they will help you further. So high sensitivity, a negative test, a disease is ruled out. High specificity, positive test, a disease is ruled in. So a highly specific test, if positive, rules in the disease. Similarly, if we let's say if we reduce the cutoff of 12 millimeters, almost no glaucoma subject would have an IOP of less than 12. So that is a high sensitivity. The other thing which you have to remember is that basically these two variables, if the values are overlying with each other, then sensitivity and specificity come at a bit of a compromise. We have kept an arbitrary value of some value over here, which will help us determine whether a disease is positive or negative. Now if you shift it a bit over here, then it will rule out people who have a disease, but that will come at a compromise. Similarly, if we shift the value over here, we will find out most of the people who don't have the disease, but in the same process we will miss out on some people who have the disease. So these are some things which have to be balanced. If you improve upon the specificity, the sensitivity gets a bit compromised. Similarly, a high sensitivity can compromise a bit of a specificity. Or for example, another example over here, let's say the values of creatine kinase for patients who have MI or who do not have MI. You keep a cut point over here, you will rule out most or get most of the patients who have MI, but in the same process you will miss out on some of the cohort over here. You keep a cut point over here. Now what will happen is that you rule out all the patients who did not have MI. But then there will be a subset over here which had MI, but your test has not been able to detect them because now you have kept too high a cutoff value. Another, just a repeat of one more example which can probably just help us practicing what I just discussed. So this was an article which came in Retina which basically dealt at microaneurysm turnover rate as a predictive marker for progression to CSME. What that basically meant is that they will measure your number of microaneurysms by an algorithm, use them, impose the images upon a computer, see how many microaneurysms you have right now, how many you might have at the end of 1 year, and then try to predict how many of these people progress to developing a clinically significant macular edema. So they said that if you have a microaneurysm turnover rate of more than 2, then your chances of progressing to CSME are less than 2. So if you had 33 patients over here who had this and 68 are false negatives. So what we have in this table is, basically this example is for you to just practice the table again. So we have true positives of 33, false negative of 14, again false positives of 68 and true negatives of 172. So what is your sensitivity over here? That is true positives upon the total, which is 33 upon 47, that is 70%. What's your specificity? Which is 72 upon this total over here, those who do not have the disease, or 71%. Positive predictive value 32%, because what we are trying to evaluate over here is true positives upon number of total positives over here. And a negative predictive value of 92%, because of the fact that what we are trying to evaluate is true negatives upon the total number of negatives. So basically, when you evaluate a test, look at how sensitive the test is, how specific it is, what is the data which you are measuring, is it continuous or not, and what are the positive and negative predictive values. And that will basically help you in comparing and evaluating whether the test which you are using is relevant for the condition where you are using it, or is it not relevant. Alright, thank you. And now Dr. Vivek will further carry on with the discussion of statistics.